This video is sponsored by the Association of Anaesthetists, A-Line, Health Education Northeast and NEMO.
In our panel discussion, we are going to be joined by Dr. Ayat Bashir, Miss Odeth Richardson, yourself, Professor Mala, and as well as Miss Karen Pearce, who was with us in our previous panel discussion. Karen Pearce, just as a reminder, is the Head of Equality, Diversity and Inclusion at Newcastle Hospitals. There we are, we're all in. Perfect. So I've got some questions from the audience and some from just listening to everyone speak. And it's been such an enriching day, I think. I've certainly learned so much about all the work that's been going on to challenge all the problems that we know. I'll start off with this question, which is probably directed towards Odeth and Karen, who I know work very closely together. So in practice, how can the BAME staff networks achieve inclusion for their members in the broader NHS workplace without members feeling or being perceived to be further isolated and set apart from their Caucasian colleagues?
Do you want me to answer that, or should I start off? I think it's something that comes up time and time again, because when we raise things within the organisation, sometimes we have white colleagues who question why we're doing it, and we have BME colleagues who feel they're being singled out, and then that sometimes causes a conversation that's a difficult one to have. I think the key to that is communication, and I think we're not always good at that in terms of sharing the information and the data and the rationale for the things we're doing. So we advertise what we're doing, but we're not always clear about why we're doing it. And I think as Odeth said, we welcome anyone into the BME staff network as just people who are allies and can help with that as well. And it's really helpful, and I think to have those conversations with lots of different people who are party to that, and that kind of spreads the word. But it is a difficult one, and it's a difficult one to answer, and I think it's a one where we're probably not quite there yet.
Mm-hmm. That's true, Karen. So when we had our first BAME staff conference in Newcastle hospitals, a lot of the BAME staff had a bit of a backlash when they went back to their normal departments, because they were seen as being special, as being singled out, etc. And so we've had to spend a lot of time working with staff to try and support their resilience, and to also get the message out there, as Karen says, about communicating why we're doing it, what we're hoping to achieve with it. And so, things start to settle down a little bit, but occasionally we still get issues where staff feel singled out and feel as if the burden of change is resting on their shoulders, which, as a member of the BME group myself, sometimes it does feel like that, but we persevere, and we do have some very strong allies who will help us to facilitate change.
I think as well, we're working with the psychology department as well, so they've offered resources for our BME staff via the staff network as well on those issues that Odeth's mentioned.
Thank you. That explains so much. I'm going to move on to the next question that we have, which is probably for Professor Rao. So before we can measure and account for excess COVID harm to ethnic minority patients, we need to accurately capture ethnicity for all patients and staff. How do you think this can be made into actually happen practically? So in reality, is it even possible? Are we missing the point by just focusing on specific ethnicities, or are we then just categorizing everyone as other?
This is one of the reasons why, even within the MRES, you will find in the first report, some of the indicators are going to be left blank, because take your Royal Colleges, the data are so incomplete. Well, if you look at the number 11, the last of the indicators, it asks for does your leadership, your diversity in the leadership of your, let's say, of your council structures. So the diversity in your council, does that match the diversity of your membership? But if the membership ethnicity data almost 50% incomplete, then you can't draw any meaningful conclusions. But with the res, what happened was that in the first year of data collection in 2015, this was exactly what was found for all of the electronic staff records of all of the employees. And the trust, because there was a spotlight on it, began to improve ethnicity data recording, and now it's extremely complete. It's taken 5 years, but it's beautifully complete, accurate data returned always on time. And that's what we can achieve if we put our minds to it. But you're right that ethnicity data are poorly recorded for both patients and staff. And then, of course, there are other data gaps, such as, for death certificates, we haven't even been recording ethnicity. So these are things that were highlighted once the pandemic got off the ground. I acknowledge it's a problem, but there are an awful lot of organizations that are now mindful that these data gaps do need to be improved.
With the rest, are you particularly looking at, within each ethnicity group, are you looking at the differences? So instead of just being, so for example, I always end up taking Asian Indian. I have some Sri Lankan friends who end up having to be Asian other, and there are lots of other Indian Asians who who come from different actual genetic makeups, and so you're looking at those within the rest.
Well, the interesting thing is we've already concluded, have we not, that the COVID disproportionate impact of mortality, of COVID on mortality on our Black and minority ethnic populations has far less to do with anything genetic than the structural barriers, such as overcrowded housing and poverty and so on and so forth, and racism and discrimination, and what that does in the way of their being able to access services. And the other thing is this notion that biologically we're different is also incorrect. So the reason I'm mentioning that is we need to think through why we are collecting individual data as to Asian Sri Lankan or Asian Sri Lankan and other, or whatever it is. There are some instances where you can justify that you do need to know. It could be about smoking habits or something like that. Even among Asians, South Asians, there are big differences in smoking rates between Bangladeshis and let's say Indian origin and so on. And I've known that data for a long time. So there may be reasons for that. But if you're looking at broader structural racism issues, such as, you need policy to do something about housing or poverty and income gaps and things like that, you need to know all of the minorities that are affected and how they're affected together. And dividing it up sometimes distracts from the issue of doing something with our minority populations as a whole. So I'm not suggesting that it has to be all one and not the other, but I think it's horses for causes, and we need to understand if we are drilling down deeper and deeper and deeper into separating out ethnic minority groups, then why we're doing that, and we need to justify it before we end up creating such small denominators that at the end of the day it's hard to actually make sense of the data at all. We know broadly visible minorities experience society and healthcare in a very different way to the white majority. We know that, and so that's a good enough difference for some purposes, but not for everything. hope that explains it. So, you know, the issue is you can't go for one or the other. And I think we could quibble about almost any kind of distinction you could make and groupings.
I agree, that does make a lot of sense. Thank you very much. We have another question that is probably best answered again by either Odeth or Karen. So a lot of concern has risen from the BME community regarding this pandemic and future employability, and this is with regards to having to go through the process of risk assessment. How can you ensure that high-risk individuals who are perceived to be of BME origin wouldn't be discriminated against when it comes to employment in the front line specifically?
I think within Newcastle, we took an approach that was maybe slightly different to a number of NHS organisations. So although we included in the risk assessment, we didn't mandate an outcome, and part of that was as a consequence of listening to our staff network. There was a range of views around how it should be implemented. A lot of people didn't want to be singled out, and a lot of people wanted to continue to work in the profession, in the field, in the ward that they'd always worked on, and didn't want to be removed from that because of the pandemics, providing the PPE and an appropriate risk assessment was done. So we really left it to individual choice following a full and thorough conversation with their line manager. And this applied to all members of staff, not just staff from a BME background, but obviously that was a higher risk profile. So we didn't mandate. A number of NHS organisations mandated that if you ticked a number of boxes, you were automatically redeployed or you were sent home. We didn't do that in Newcastle, but we addressed every case on a case-by-case basis. And the feedback we've had so far has on the whole been really positive, because people have been enabled to do what they feel comfortable doing. So no decisions were made on behalf of anyone else. They were part of the decision as to what would happen in terms of their anxiety levels or their profession or whatever they wanted to do during the pandemic. And it's a fluid process, so we've said people can revisit the risk assessment. Just because you've had it done and it led to one outcome doesn't mean to say that you can't renew that risk assessment and it lead to a different outcome. People's circumstances change and people's levels of anxiety and levels of resilience change.
Yeah, and one of the other things we did was, if staff felt that they couldn't have that conversation with their line managers, we were able to do it on their behalf as part of the network. And we also had support from occupational health who were able to do that conversation. So it's people were given the choices, we didn't mandate it.
That's brilliant. That's a really good, it's a unique take to take. And like you said, not a lot of trusts have used that, which ends up meaning that a lot of people feel like risk assessments end up being a tick box exercise. Could you tell us anything, Odeth, about how this staff network was set about and how perhaps other trusts that haven't got a network as big and up and running as ours in Newcastle can make that happen?
I'll let Karen do the preamble first in terms of the res, because she was always the one who did the reporting, and then I will pick up once she does that little bit. Go ahead, Karen.
Was it in relation to the staff network that you wanted to know?
We started, yes.
So the staff networks have been in place since 2014, and probably from around that time we'd done a lot of work or increased our portfolio in terms of equality, diversity and inclusion. I think, if I was being honest, prior to that, I don't like the word tick box, but I think we did the minimum that we needed to do to keep us the right side of the legislation and all the requirements. And I think very slowly and gradually we've increased that, and we do an enormous amount of work now. I think in 2014 was the beginning of that journey. And we took the opportunity in the first time we launched or celebrated NHSE and D Week, which is May every year for the NHS. So we launched 3 staff networks. I rang countless places, private sector, public sector, who had staff networks, and every single one of them had a different approach. And it was one of those situations where you can say, I can keep ringing round and not come up with the ideal scenario, or we can just publicise it, launch it, keep our fingers crossed and see what happens. So I'd like to say it was a little bit more planned than that, but it literally wasn't. We put it out there. We come up with some branding the year later just to, have the feel of it. really good. And I think we started off with less than 10, single numbers on each of those staff networks. Disability, LGBT and BME were all launched at the same time. And our BME staff network has grown massively. It's the biggest of all three now. And it's just a case of promoting. A lot of people within our organisation, I think, would probably still say they don't know that we have the three networks. So again, it comes down to communication. But it's just communicating that and advertising it as you go in, and demonstrating the value of the staff networks by publicising a partnership approach, and it is a real partnership approach in Newcastle, and I hope Odeth would agree with that.
Yeah. So I think one of the things that you forgot to mention, Karen, is that the network came out from the staff survey results. And these three groups in particular were saying that they didn't have a voice, they didn't feel they could be heard in the trust. And so that was a decision taken to create these three staff network groups. I can't remember how I got involved, but Karen probably just wrote me in.
You were the first person who joined up, Odeth. I remember.
So yes, I was, I guess I got involved from a personal point of view, because when I started in Newcastle just over 10 years ago, my experiences weren't very good in terms of racism and things like that. So I felt that I had a duty of care to sort of try and make life easier for those coming behind me, because I didn't want anybody to experience what I experienced. It's a very different organization now in terms of where we're at and the changes that we've made and the developments, and we've really grown. And it is really, really interesting to look back 10 years on to see how much we've changed, how much we've grown. We are trying to get a bit more inclusive, and there's lots of work going on, and we are making progress.
I would say as well, for organisations that are just starting that journey, to stick with it, because I think Odeth would agree, for the first 3 years it was often me, Odeth and another in a room, and now it's much different to that. But I think it's only really took off in the last 2 years. It's been not easy, and you've just got to keep with it.
Yeah.
Dr.
And
Bell.
that's for help. We're happy to support any network for those sort of networks who are sort of young and growing. We're quite happy to provide support. So if you feel that you need some support from us, do reach out, and we'll do what we can to support you to get you to where you need to be.
Super. I thought I saw Dr. Bell's hand go up.
I'm afraid in my typical fashion I was going to veer off, and I just wanted to ask Dr. Bashir, there's such a lot of energy in the Black Lives Matter campaign, and as very much an outsider to that, a lot of it looks very angry. How do we harness that energy into a positive way of taking this issue forward that will include everybody, so nobody is afraid to ask about it because they're worried about asking, I suppose? I'll give us a personal example. I hope my colleague who may well be listening doesn't mind. I was doing an appraisal a short while ago with a colleague from a Black ethnic minority, and we spoke an awful lot about coronavirus and so on and so forth, and we spent a couple of hours doing this appraisal, and eventually they asked me why I hadn't asked them about the Black Lives Matter campaign. And I admit, even though I've known this colleague for a long time, that it was my own cultural reticence to ask about those matters that prevented me from saying to my colleague, I know about Black Lives Matter, how has it affected you? I wasn't even sure that that was an appropriate question to ask. So I would be grateful for some thoughts on how, as a middle-aged white female, I might engage with that energy in a positive way and not be afraid or feel I'm being culturally clunky by asking the question.
Yeah, thank you. That's a really important point. I've got a lot of friends who probably have experienced the same as yourself. And what was actually really reassuring to see in the Black Lives Matter movement is, I'd look at the protests, the people with such varied backgrounds. So it wasn't just all sort of Black people protesting or all Asian people protesting. It was actually it was everyone who was angry with that, and it did feel, although it was it felt like it was angry, but it also felt like it was that we were supported by the people of different ethnicities, even by white people, and that was the positive energy from that. And I think that what we could take forward is if it's spoken about freely in the trusts, for example, and kind of having it very, very informal, rather than kind of a formal, okay, this is a Black Lives Matter Day, can you guys come to it, and these are the speakers. It needs to be very informal and kind of more social. I think Professor Nimita Kumar talked about social engagement earlier on, and that's what we need, is people to be comfortable in a comfortable setting, rather than and potentially it might be that we need to say, we're happy for people to ask us about this, and I think that might be just a simple answer, but then again, I think we just don't need to, I think, force it in terms of, make it formalized, or we need to talk about this in a formal manner, rather that what I want to do in the workplace, how I'm going to feel comfortable, is when people, we all go for lunch and it's going to be general sort of chit chat at lunchtime, or over coffee or a morning breakfast or whatever. That's what I see would be the way forward. But yeah, I agree. I think a lot of people feel uncomfortable, and potentially it might be that people of ethnic minorities just need to say, please come and talk to us about it. We're happy, and don't worry. And that, I think that's probably, from a personal point, that's what I would want someone to do, is to just say, just go for it. Don't worry.
And just a follow-up question, probably to both Sonia and yourself, as the trainees. As trainees interacting with your trainers, is how do we support you in that respect as well, not just as colleagues but actively as your trainers, in terms of educational supervisor meetings and that type of interaction, where we're going through a process but there isn't a box on the educational supervisor form about asking about the Black Lives Matter campaign, or so on and so forth. So is that something we can, or should you use that process of that one-to-one to be supportive, or to inquire about in a genuine fashion, rather absolutely not being a tick box, but that genuine inquiry? Is that helpful as a trainee, or does that make you feel a little bit more excluded almost, because we're doing some different interaction with you than we are with our UK white graduates? I am in a state of confusion, I have to admit. I feel I can get so much wrong on any given day that I think sometimes that can be a little bit, it can put a barrier up. So I'd just like your thoughts and advice on that, really, as a trainer.
I'll let Ayat speak first.
Certainly I think in sort of education supervisor sort of appraisal meetings or the end of rotation meetings, it does seem like a very much tick box exercise, and sometimes it's rushed. It's kind of, everyone's really busy and you're trying to get through it, and your deadline's looming. So sometimes it might not be, you might not feel like people are sort of will easily volunteer that information. Rather, I think, and also, and I remember in sort of the e-portfolio tick boxes, so have you had any health issues during this rotation? And everyone's going to say like, no. Even if you had, they'll just say no. So I think it's probably more that if we if it's more kind of you, like the trainee volunteers, or can I have a meeting with you? I've had this issue. And generally, at the beginning of the rotation, if you've had, just to kind of say, if you've had any issues, discrimination, racial problems, if anything's affected you from the media or anything like that, please come and talk to me, and we'll arrange a meeting. Not specifically at the end of the appraisal meeting, because that might be too late, and it might be at the beginning of the rotation, potentially.
No, that's really helpful, yeah. Any thoughts from your point of view, Sonia?
I completely agree with I think and with yourself, Dr. Bell, it's sometimes it's a two-way thing, where a trainee would have to come across open enough to feel comfortable to discuss this, and same with the trainers. It's always the small things that matter. So things like being able to take annual leave on important religious events, which might not be recognised as much in this country. So being able to not be on call on Diwali is a big thing for me. And I've always, every trust I've worked in, every hospital I've worked in, there's always been the trainers, or all our consultants have always been fantastic with giving us, you know, a bottle of wine or a box of chocolates around Christmas time. But even just oh, I notice this or the other is coming up this weekend. Have you got anything planned for it? So personally, I haven't got any family in the UK. My parents live in Kenya. So I usually don't do very much for big occasions, but you know, I've had a lot of people approach me on Christmases saying, come spend it with us, consultants that I've barely worked with, and it's that sort of interaction that is really, really supportive and, you know, is very much appreciated as a trainee.
Yeah, okay. Helpful. Thank you, ladies. I'll shut up then.
We have a few more questions, and I've completely lost where we are. So we did talk a little bit about or Professor Rao rather talked a little bit about looking at medical school and how how the students proceed through medical school, and kind of starting the discussions earlier on. So in terms of what can be done to tackle things like differential attainment and racism at the medical school level before we end up getting to the point which Ayat described in her talk of starting a foundation year and then being told you need to be really careful about your appearance because you might have to work extra hard to prove yourself. Dr. Rao, any comments?
Oh, are you asking me? Sorry. Yes. Yeah. Well, you know, there are some people like Professor Catherine Wolfe from University College London, who's done a lot of work in the undergraduate years to just think through what the issues might be. And one of the things she's very clear, and this is her language, that you know, it's not learner deficit which explains these differences. It's actually environmental, the learning environment deficits which explain it. And it's not dissimilar to what happens at your during your junior doctor years, which is those informal networks. You know, how do you study? How do you learn? You know, are there groups that are excluded from the sorts of groups that would have an ease of access with lecturers and people like that, maybe through sporting activity or some other form of socialization, which allows students and teachers to mingle, to occasionally get not confidential exam information, but just a pat on the back, you did well in that test, or you did well in the tutorial, or some such thing. So it's both the encouragement, the recognition, the pat on the back, which is such a boost to students' confidence, but also maybe informal tutorials, which are held in you know, in social small gatherings, which Black and minority ethnic students might find themselves excluded from. And that could be down to a poverty issue, it could be down to religion, it could be all kinds of things which exclude you know, some students from some forms of socialization. I think it's about both staff and other students being mindful of that. And I know that in UCL, they're trying different ways of making tutorial groups instead of allowing people to choose their little group, you know, to mix and match so that you've got different ethnic origin students mixing and you know, enabling them to be friends. And actually it's been fabulous because people have discovered that there's an awful lot in common anyhow among medical students. It's the same sort of worries about getting through exams or how you're going to pay back your grant or whatever. And you know, so that is beginning to work and start to boost student assessments. But it's that sort of thing rather than anything else which probably makes the biggest impact.
Very much like you suggest, it's an environmental deficit How do you think we could tackle these challenges where students or even trainees and doctors from a BME background feel that they're judged, particularly on kind of non-verbal communication? So what can we do, you know, as a hospital, as trusts, or just generally as a profession to overcome their fears of speaking up, to prevent them kind of bubbling or shutting down, or bottling up rather?
Yeah, I think the thing is about champions, as you know. Perhaps you're already aware that in Cardiff Medical School, this was actually a little news report which was included in the Racism in Medicine special issue of the BMJ, which is published on the 15th of February. And I'm not suggesting you might all be interested in looking that up because I was a co-editor, but because it was such an absolutely a privileged opportunity to bring incredibly interesting information together. And the amount I learned from it was amazing. But I hadn't realized that in Cardiff Medical School, there had been a really horrendous incident only as recently as 2016, when there'd been at a review, a freshers review or some such thing, such a terrible set of racist and homophobic jokes and all sorts of things told so openly that in fact students were suspended, and there was a committee of inquiry set up to look into this. So this was not even covert, it was pretty overt, you know, the abuse that some teachers had, you know, Black and minority ethnic teachers and students. So at the end of that, the medical school acknowledged that they had not done enough. They assumed things were great on campus, which a lot of white people do feel. You know, in our own families, I've got, you know, white people who were not all the time as conscious about these issues as Black and minority ethnic people are, because it's not their lived experience. So the school had evidently believed that you know, there was no racism on campus. But this was an incredible wake-up call, and they completely refreshed how things would be, brought in student champions, and there's a flourishing African Caribbean Medical Association, and students belonging to it are from both white and Black and minority ethnic backgrounds. So I'm not suggesting that every school should go through that kind of experience in order to discover what's wrong. But on the back of that, medical schools everywhere are putting together student champions from both Black and minority and white backgrounds who are keen to bring about equality. And perhaps, you know, coming together of those who are interested in LGBT or gender diversity or race diversity, coming together and becoming champions for a better environment in which everyone can thrive is one way by which, you know, change could happen, and happen quickly. And they are students who can look at the curriculum and see whether that applies to and benefits the discussion of Black and minority ethnic issues. In what way do curricula, methods of teaching, and all of that, how does it need to change? You know, if you ask people, staff and students and teachers and so on, they do know what's needed. The reason why you never get to hear about it is nobody asks them that question. So by asking and becoming more proactive in finding solutions, it's staggering how much good can come out of that sort of thing.
I completely agree. Dr. Bell, as TPD for trainees with differing needs, is there anything you'd like to add on? Oh, we can't hear you.
That's because I closed myself off. I think the depth and complexity of this is evident. And I think one of the messages I've got from today is that when I meet a trainee in difficulty or with differing needs, it's a very long chain of events that have got that individual to that point. I think I do recognise that genuinely, but I am sort of fighting the fire with that trainee. At that point, we've not been able to influence how that trainee ended up at that point of tripping up in their training. And I think it is essential that this element is discussed and integrated and embedded much earlier in medical school selection and in training, and for those joining our training program right at the very beginning, being explicit as to where we are and how they might integrate with our system. Because as TPD for trainees with different needs, it's almost a pity that I need to be here at all. It would be lovely to get to a point where I didn't have a job because there weren't any trainees with differing needs, but at the moment that's not the case. But I do think as a region we have done well in discussing elements of difficulty that trainees from all sorts of backgrounds experience. I think our network of college tutors is fantastic and really much more aware and understanding of how trainees get into difficulty and trip. I think as we roll that back, it's going to have to be earlier on in the process to start making a fundamental difference. Because I think at my end of the problem, and I hesitate to call it a problem, perhaps issue or difficulty, I'm trying to fix something that's been broken much earlier in the system. So I think what Professor Rao was saying, and also Dr. Bashir, and well, everybody, it's about starting with the level playing field. We're trying to level the playing field that's been upended for years, and we're trying to push it back down again. I think the momentum that we need from the Black Lives Matter campaign, from Professor Rao's REST data, from Odeth and Karen's BMA networks, is to make that playing field level at the beginning and not try and mend it at the end when something is perceived to go wrong. And I think that's a very big ask, but actually that's my take-home message at the moment, if I can put it that way.
Thank you very much. That's pretty much concluded what I certainly think, and I'm sure a lot of our audience do as well. Go on, Professor Rao. Well, we can't hear you either.
I wanted to add a little to what Professor Bell was saying. I mean, I think that's so true. And you know, even in recognizing it, that's half the job done, because it's, you know, it's once something starts to be done. I think you've got Black and minority ethnic students, junior doctors, you know, very amenable to working with tutors to write those difficulties. But you know, one of the interesting things for me, I don't have time to talk about the induction program. For international medical graduates, we're talking about junior doctors. It's extraordinary that in what is it now? You know, 72 years, we haven't had a standardized induction program for international medical graduates coming to this country. And you know, and I went and did some focus group discussions to ask them what they'd like, because that was the top priority. Stakeholders said to me, if you get the MRES off the ground, and there must be an induction program. And many of them were so fearful, they didn't want to talk to me. And those that didn't want to disclose their names. These were telephone discussions. They were in 2019. So the COVID Zoom, you know, environment hadn't quite arrived at that stage. On the telephone to tell me some pretty innocent things. Like they said, for 3 months, we didn't have a bank account. Nobody in the hospital told us how to set one up. We didn't know we had to rent accommodation. I don't know if all of you have read this amazing book that I loved. It was called Eleanor Oliphant, you know, is very well or something. Is all right, I think. Now, Eleanor Oliphant is this woman who has nobody to talk to between Friday evening and Monday morning. And a lot of the international medical graduates are saying the same thing. It's handing over notes during the day for much of the week. But then during the weekend, I have not even that, handing over notes to do. So the asks were so modest, and yet we have never recognized the need for social integration and how a little bit of what we can do can make such a big difference. So in that difficulty, the reason why I'm mentioning all of this is the difficulty starts with our complete lack of any social integration into the NHS and life in Britain, right when international medical graduates join, or end up in this country. The MTI and things like that, they do have some, but the formal induction is usually about, here's how we do notes, or here's how we, patients or whatever. But the socializing and how to feel part of a group, valued, respected, loved even by the whole community, that doesn't happen at all. And unless that happens, they're already being set up to end up with some difficulty. So thank you.
I completely agree. I think there's definitely a loophole in the whole process of getting international medical graduates to come work here, and then almost just throwing them into the deep end without so much as a structure to induction, like you said, even though this happens nationally for years. So hopefully in the future we'll be able to set something up that will be standardized and has people like yourselves, Odeth and Karen, so staff networks involved quite early on, so that people feel supported and feel like they've got somewhere to go, some champions to go to help with even just the little things like setting up bank accounts, or just creating a network of friends. And with that, I think we'll conclude the panel discussion, unless anyone of you has anything else to add or any questions.